I'm here to talk about the state-of-the-art diagnosis and treatment planning, the triangle of bone concept. It's a concept that I came up with approximately in 1993, which was followed by an article in 1995 and then several articles over the last 12 years that illustrate a particular concept that I think is very helpful when we do treatment planning, diagnosis for not only implants, but for bone grafts and other concepts as well, as I will hopefully discuss in this brief amount of time that we have together today. When we're dealing in three dimensions, it really has opened up all of our senses in terms of how we evaluate all of the cases that we do with implant dentistry today. I will give you some examples of that in terms of pre-surgical process planning, because to me, that is the heart of what we do with implant dentistry. The goal of implant dentistry is the tooth that we replace. And in order to be able to achieve that goal, especially when we have advanced accelerated treatment protocols today, we have to really start with true restoratively driven implant dentistry. And in the past, we have tried to be able to accomplish that by, as an example, using a model-based surgical approach or cast surgery where we remove some of the stone from a model and then we try to place an analog into that area where we would like to replace it with an implant. And we can do that not only to be able to assess the placement of the implant spatially, but also to be able to preserve the surrounding architecture, such as you see here in the soft tissue in the interdental papilla, as well as the alveolar sulcus. And we need to be able to support that during the entire healing phase so that we don't lose that valuable piece of real estate, which of course in this case is the soft tissue. So we want to be able to replace everything that's missing, and today we have all of the tools to do that. However, do we really have all of the diagnostic tools to know what is missing from each receptor site that we're looking to replace a tooth? And so when we're looking at a model-based surgical approach, we can in fact try to preserve that alveolar sulcus and the surrounding soft tissue, and then we can bury an analog. And we've heard over the years of many of the different concepts. How far do we place the implant? Is it below the CEJ of the adjacent teeth? Is it below the crest of the bone? How far facial do we place the implant? How far palatal do we place the implant? What kind of inclination do we need? How much bone do we need from the facial lingual aspect of our implant to be able to have a proper emergence profile and restore the case, especially in an aesthetic zone situation, as I'm showing right here? Once we place the analog within the stone model, we also today have to be very cognizant of the rotational position of the implant. So now we're looking at, in this particular case, an internal hexagonal connection, and manufacturers create that connection not only to be able to drive the implant into the site, but also, of course, to achieve a connection between the implant and the prosthetic component. When we want to achieve a level of accuracy and consistency, my concept has always been to try to arrange that anti-rotational feature so the flat is towards the facial at all times. If we only can achieve that during the surgical placement of the implant, it will make the prosthetic reconstruction that much more consistent, easier, and more accurate, because the manufacturers create their prosthetic components based upon some anti-rotational location. And of course, it's always pointing towards the facial. So if we take that in consideration when we're doing model-based surgery, it will give us a head start on the prosthetic reconstruction. We bury the analog, and we're going to go into a little more detail on exactly how we assess the depth and the position in the examples that I will give going forward. But when we're dealing with a model-based surgery, we're really missing some of those landmarks. How can we really tell where the CEJ is? How can we tell where the root morphology might be on one adjacent tooth versus another? And so we have to go by certain guidelines when we're doing model-based surgery, and we're going to bury that. We're going to keep a distance of at least 2 millimeters from the facial aspect of the outer part of the bone to the outer aspect of the implant, and hopefully get this right within the middle mesial distally of the adjacent teeth, following the incisal edge of the adjacent teeth to be able to have a proper emergence profile, which of course is going to be supported by a prosthetic component. And in this particular case, we're looking at a we're looking at a prefabricated abutment. The prefabricated abutment is created in this particular case from the fixture mount transfer, which is made out of titanium. You can use a custom cast post, you can use any other kind of stock abutment, and you can even use a computer milled CAD/CAM abutment in this case as well. And so the abutment will support the prosthetic reconstruction, in this case a single tooth, and we will hopefully be able to have the patient come in, extract the tooth, place the implant, orient the flat of the hex towards the facial, place the prosthetic component on top of that, which is going to be the prefabricated abutment, and then cement a restoration, in this case a temporary crown. We could also design this as a screw-retain restoration if the site demanded it. And so here you see an analog, the prefabricated abutment and the temporary restoration, and it looks like a tooth sitting upon its root. And that's what we want to try to achieve in our pre-surgical prosthetic plan. Today we have new methods, though, that take the guesswork out of what we're doing. So we're no longer looking at a stone model, which doesn't give us the true information about the underlying bone. We have the ability to use other advanced types of technology, such as stereolithography, which allows us to be able to have a bone model of the actual patient's anatomy, so that there is no longer any guesswork. And then we can transfer the information from the planned placement of the implants, from a interactive software application that allows us to be able to analyze CT scan data, creating a surgical template which can allow us to take away most of the decisions that we have during the surgical phase, because here the decisions have been made already in advance during the planning phase. We can't lose sight of the fact that we always have to go back to sound prosthetic protocols and anything that we learned in dental school in terms of how we restore our patients. And that involves mounted articulated models, understanding vertical dimension, understanding lip support. All of that is included in the pre-surgical prosthetic phase. When we take a page out of Schillenberg's book, we can see that he gave us an example in terms of understanding crown-to ratio, which I think is an important consideration. And there are two examples here in this illustration. One is a healthy dentition. This is a tooth sitting in the surrounding bone, the surrounding soft tissue. And according to Schillenberg in his textbook, and by the way, I have added some color here because my edition was still in black and white. And so I have, in fact, enhanced and modified this image. And when we take a look at this, we see the crown-to ratio, as Schillenberg has defined it, is the top of the incisal edge of the crown to the crest of the bone. The crest of the bone to the apex of the root is the root distance. And so crown to root distance in a perfectly healthy dentition, according to Schillenberg, is 2 to 3. When we look at a compromised site, we have a diminished crown to root ratio. So now we're looking at a 1-to-1 ratio in this illustration. The problem here is that this is actually representing a cross-sectional view. But in reality, it's an artist's interpretation. It's an illustration. And when we envision this, as we unfortunately can, because our manufacturers and the literature shows us that we can potentially place an implant within this site where the root used to reside, we can place an implant into this area, we can place an abutment on top of it. But is this the true reality of what we see in terms of the anatomy of that site? And unfortunately, we've been led down a path, because if we take a look at the perfectly intact dentition as Schillenberg has described, the reality is that this does not exist in real life. And the only way that I've been able to learn to assess that anatomy in 3 dimensions is through the use of CT scan technology. So let's move forward and discuss some of that technology. If we take a look at the evolution, that the most important technological innovation that helps clinicians understand and assess patient anatomy has been the evolution of CT scans, whether it's medical grade or cone beam CT scan machines today, and the interactive treatment software that allows us to be able to plan cases with incredible accuracy and precision. And so I'm going to walk us through protocols that I believe are important to be able to utilize this technology in everyday practice. When we assess, as an example, a 16-year-old individual, someone who has no decay in their mouth, the only reason that we are taking a CT scan here is to evaluate a pre-existing condition, congenitally missing lateral incisors. And when we take a look at this young individual, we can see in this cross-sectional image of the central incisor that we have the root, we have the developing pulp canal, we have the physical crown, as you can see, the incisal edge, the cingulum area, and the alveolar process that holds the tooth in place. If we look a little bit higher, superiorly, we see the floor of the nose and the nasal concha. And when we're looking at this, we can see and appreciate the amount of bone that exists around our real natural teeth. And this is a 16-year-old individual. Keep that in mind. When we take a look at the canine tooth, we can see it's a slightly different trajectory. We can start to pick up a little bit of the maxillary sinus in the superior anterior area, and of course more of the floor of the nose, the hard palate. And so my question has been, in evaluating healthy dentition, where we can see the root, we can see the CEJ and the clinical crown, where is the bone? Where is the bone that Schoenberg has illustrated to us exists? Well, it really doesn't. And that should impact upon how we treatment plan and how we diagnose our cases, for not only for the implant placement, but also for potential bone grafting as well. And so that question, where is the bone, is going to be a theme of this discussion right now. Because if we continue with the premolar case, as you see here, you can clearly see that if we follow the outline of the cortical plate of bone on the facial, there almost is no bone on that facial root. If we look at the palatal root, you can see that if we followed the extraction site with a drill to create an osteotomy within this area, we would in fact be in good host bone. If we utilize the facial root to be able to place an implant, because that's where the drill may follow that path, we would clearly be out into the vestibule, which is not where we want to have an implant placed. And so you can understand how accidents can happen. But if we have a pre-surgical prosthetic plan and we can assess this with CT in 3 dimensions, we will avoid those potential errors. When we take a look at the molar area, we can very clearly see how patients could have issues in terms of the maxillary sinus and allergies, and when the patients complain that they have pain or sensitivity in their molar teeth, and you take x-ray after x-ray, you find no pathology. Well, you can see very clearly that the roots of the molar teeth are bathed by this area of the maxillary sinus. And again, where is the bone around the facial and the lingual aspect of this molar tooth? So we don't have the volume of bone that maybe we have in our minds, as illustrated by Schoenberg's book and many of the other illustrations that we have in implant dentistry and regular restorative dentistry today. When we look at the developing dentition, we can see that as the teeth emerge out of the bone, as we push out the deciduous teeth, again, there is no huge bone volume that these teeth are coming from. So that makes us change maybe our mindset and how we evaluate, diagnose, and treatment plan our cases using this new technology, and certainly has evolved over the past 18 years. So in the article that was published in 1995, I described the triangle of bone. And the triangle of bone concept really is it's a zone. if you will. And that zone is what we would try to evaluate a cross-sectional image to see if that's a proper receptor site for an implant. And if we take a look at the simulated implant here, because as we started with interactive software applications, we were only able to utilize representations or schematics of an implant. And here you see a schematic of an angled abutment, because we don't want to forget the prosthetic reconstruction, which is, of course, the goal of implant dentistry. And as this technology has evolved, through this article that came out and published in 1995 originally, I was able to describe this zone, this triangle of bone. And the widest base of the triangle represents the widest available bone that we have here in this cross-sectional view. The apex of the triangle is where the crest of the ridge should be bisected. And if we can place that implant within the body of this triangle, you will have an implant that is surrounded by the most volume of bone. Of course, the bone has to be there to begin with. And we'll follow that concept as we go along. So as the technology has evolved, you can see that we've gone from a two-dimensional cross-sectional image to an actual three-dimensional cross-sectional image. And in fact, we've actually been able to incorporate realistic implant shapes, realistic implants that have thread designs and have vents and have apical coronal aspects that really, truly represent the implant that we're going to place, the manufacturer-specific implant for that area. So this gives us a tremendous control over the planning phase for our implants, all within that triangle of bone concept. So if we follow the progress of how this works, I will show you how this really can be used as a tremendous diagnostic tool and a decision-making tool when it comes to determining whether or not we should place an implant. Here you see a cross-sectional slice that shows a hopeless tooth. You can see the alveolus, the alveolar housing, and perhaps this tooth has had apicoectomies in this particular area. If I outline this in color, you can see where the alveolar crestal bone is and the housing that we have here, but you'll notice that only a small amount of that bone really supported this particular tooth root. When we show this particular root, you can see perhaps where the root used to be before an apicoectomy, and still, the question is, where is the supporting bone? Well, the supporting bone is here, in this area. And so I think what we've seen at many of the podiums over the last few years is a complete reversal in some of the ideas of where proper implant placement should be. And it really evolves and revolves around this process of determining where the triangle of bone is. So let's determine how we create this triangle. The first thing that we're going to do is we're going to identify the widest area of bone in this cross-sectional image, and we'll label that point 1. We'll draw a line and connect the dots to the palatal or the lingual aspect. That will be dot 2, and then we will connect this at the crest of the ridge, bisecting that ridge, and we'll connect that dot as dot number 3. And so now we've defined this triangle. And we now have to look within that triangle, and we have to determine, is there enough bone within that triangle to place an implant? But yet, if we only look at this cross-sectional image, if we only look at this triangle, and we do not understand the prosthetic implications, then we're missing part of the entire equation. So now that we've defined that triangle, we have to go one step further, and that is to connect this to the prosthetic reconstructive phase. Because the goal of implant dentistry, of course, is the tooth. And so what we're going to now do is we're going to bisect the triangle. And if we can do that, we certainly will place that implant into the most available host bone. And so here we are with the new number 1 dot, which will be at the complete bisection of this triangle. We'll connect it to the apex of the triangle, and then we'll connect that dot to the incisal edge of the planned restoration. Because the position of the tooth, unless there's a malocclusion, should always remain constant. So now that we've connected that dot, we can go back, we can look at the triangle, we can look at the restorative requirements for this particular area, and we can place a simulated implant within that triangle. And then we can look at the angulation, the trajectory of the proposed abutment, and determine the prosthetic reconstructive needs to be able to connect the implant to an abutment to support a crown. So when we take a look at the cross-sectional image in 3D, we can take it to another level. And that new level is to be able to utilize manufacturer-specific implants, the real CAD-generated drawings that are used to be able to create the implants that we use every day, and we can incorporate this into the interactive software, not just in a two-dimensional cross-sectional view, but an actual three-dimensional model. And that, to me, is an extremely important evolutionary step in the progress of this wonderful technology. The concept that I've just described has been published in many, many articles over the years. The most recent was an article titled The Reality of Anatomy in the Triangle of Bone, which was published in Inside Dentistry back in June of 2006. This can be downloaded from my website, which is www.drgans.com. And plenty of these other articles that I will allude to, perhaps, you can download as well if you want to have further information. So I believe that when we look at implant reconstruction and we look at bone grafting, we look at even third molar extractions, impacted canines, that we're really moved into a whole new generation when we're dealing with CT imaging. And so I believe that there is a danger when we were bound by two-dimensional concepts when, of course, today we live in a three-dimensional world. And so let's move from the two-dimensional periapical radiograph to something today that is really tremendously useful, and that is the realm of 3D imaging and 3D imaging technologies.